Hello, everyone. I'm Lisa Forsberg. I'm a British Academy postdoctoral fellow in the Faculty of Law and the Oxford Uehiro Centre for Practical Ethics at the University of Oxford. It's my great pleasure to welcome you to this epidemic ethics seminar on ethical issues and considerations relating to children and COVID-19 vaccinations. The vaccination of children against COVID-19 has turned out to be quite controversial. I think to an extent that at least I've found quite surprising. But the fact that it has become a contentious issue makes it all the more important to clarify and discuss the relevant ethical issues and to think systematically about how we should approach them in practice. It's therefore really fantastic to have the opportunity to discuss these issues today with our excellent panelists. The kinds of questions that we will be considering today include how we should think ethically about vaccinating children in light of the risk-benefit profile of vaccination compared with COVID-19 infection. So this concerns the risk-benefit profile in terms of their health, but also their broader well-being interests. A related question concerns how we should think about the uncertainty involved in the decision to vaccinate or not. Another distinct question concerns whether vaccination should be mandated in some way, for example, in schools. We might also consider whether and when off-label use of approved vaccines would be permissible in jurisdictions where vaccines have not yet been authorized or recommended for children, or where they've been recommended only for certain age groups, for example, older teenagers. And we'll consider a very important question, which is how we should prioritize children for vaccination, given that many vulnerable adults, especially in low and middle income countries, still lack access to vaccines. Our excellent lineup of speakers today includes Anthony Skelton. Anthony Skelton is Associate Professor in the Department of Philosophy and the Rotman Institute of Philosophy at the University of Western Ontario, Canada. Anthony's primary research interests are in moral philosophy and its history. In moral philosophy, Anthony has focused on the nature of children's well-being. And recently, Anthony has written with me on the ethics of mandating COVID-19 vaccination for children, and also on some of the other issues we'll be discussing today, such as how we should think about the vaccination of children in relation to lack of access to vaccines in low and middle income countries. We're also very fortunate to have with us Beate Kampmann, who's a Professor of Paediatric Infection and Immunity and Director of the Vaccine Centre at the London School of Hygiene and Tropical Medicine. Beate is also the Scientific Director for Vaccinology Research at the MLC unit in the Gambia. And she directs a comprehensive childhood infection and immunity research programme, both in the UK and in sub-Saharan Africa. Beate has recently written on the importance of including pregnant women and children in vaccine trials for pandemics, and about the equity issues that surround COVID-19 vaccines for children in low and middle income countries. We're also very fortunate to be joined by Govind Persad, who's Assistant Professor at Sturm College of Law at the University of Denver. Govind's research centers on the legal and ethical dimensions of health insurance, healthcare financing, both domestic and international, and markets in healthcare services. He also works on professional ethics and the regulation of medical research. Govind has published widely on the ethics and priority setting in response to COVID-19, including vaccination prioritization. So thank you very much to all of you for joining us today. And with that, I'd like to hand over to our panelists for their 5-minute introductory remarks. Anthony, would you like to start, please?
Okay, so children and COVID-19 vaccination, ethical issues and considerations. So as Lisa mentioned, this research is conducted between her and I. And what we did for this presentation is we looked at some of the questions that we were given and we provided some answers to it. So one of the questions is, should we vaccinate children against COVID-19? The ethical considerations speaking in favor of vaccinating children aged 12 to 15 involve direct and indirect health benefits, including prevention of death, severe infection, long COVID, and mental and physical health costs of school closures. In addition, there are broader well-being benefits, including increased opportunities for social engagement and sports. In our view, these outweigh the risks of vaccination. The most reliable evidence suggests, for example, myocarditis, which is considered to be a risk factor in vaccination, is much more likely to occur from infection than from vaccination. Even the Vaccine Risk Adverse Joint Committee for Vaccination and Immunization Advisory Panel in the United Kingdom agree that vaccination against COVID-19 is on balance beneficial for children. And the JCVI conclude this despite assuming that the costs of vaccinations should be assigned greater relative value in any cost-benefit analysis than benefits of vaccination, and assuming that some important benefits like long COVID prevention being left out of the health perspective they rely on in their decision. We think if you reject the idea that costs of vaccination or risks of vaccination are to be weighed more heavily than benefits in a cost-benefit analysis, and you include in the health perspective things like long COVID prevention, you get a favorable risk-benefit ratio for children for vaccination against COVID-19. Another question that we were asked is, should we mandate vaccination against COVID-19 for children? In our research, Lisa and I say yes. And our argument roughly is that the ethical considerations, the direct and indirect health benefits, and the broader well-being benefits speaking in favor of vaccination against COVID-19 favor mandating vaccination itself. Part of our argument turns on the idea that the state has an obligation to protect children from parents or guardians who might expose children in their care to easily avoidable risk of harm and death and lost well-being. Mandates facilitate the meeting of this obligation, for example, by requiring removal of an individual from a social environment like a school in the absence of vaccination. The reasons favoring mandates outweigh any reasons against, for example, the value of parental discretion, and importantly for us, bring the approach to children and COVID-19 in line with how we protect children in other domains, like in car seats or using car seats, and in other infectious diseases. Many jurisdictions, my own included, will have mandates for vaccines for entrance into school. Okay. One objection to vaccinating children is that it would be unfair to vaccinate healthy children in high-income countries before vaccinating more vulnerable individuals in low and middle-income countries. And so that's a reason not to vaccinate them. So should we vaccinate then vulnerable people in low and middle-income countries before vaccinating children in high-income countries? Here is our argument in response to that question. The question assumes, sorry, that was too advanced, that there is a vaccine shortage forcing us to choose between children and vulnerable individuals in middle-income countries, right? Shortage is not really the issue with respect to vaccination, evidenced by the hoarding and waste in high-income countries like Sweden and the UK. In the United States, for example, 15 million vaccines have been destroyed since March. The ethical consideration of fairness then speaks in favor of redistributing vaccines to low and middle income countries. However, a fairer distribution or protection for vulnerable individuals in low and middle income countries cannot be achieved merely by high income countries donating small portions of their vaccine supply, for example, the vaccines they would otherwise have used to vaccinate their children. Donations are, of course, good and laudable, but accepting the narrative that we have to choose between children and vulnerable adults in low and middle income countries diverts our focus from the urgent need to consider what we think are more radical solutions. These include relaxing intellectual property rights and sharing vaccine recipes, ingredients, and so on to low and middle income countries so they can make their own vaccines. In our view, this is likely to issue in significant welfare gains, and so meets the obligation of beneficence, which in our view is as important as the obligation of equity, and also gains in terms of empowering countries to act in accordance with their own ends or goals effectively, so helping with the value of autonomy. At present, instead, there's an ongoing campaign for temporary IP waivers, which some high-income countries, like Sweden and the United Kingdom, are actively blocking. This is a violation of our duty not to harm people. Overcoming this should be our focus. Now, of course, it might be objected that living up to these duties will involve uncompensated sacrifice on the part of high-income countries. But it's far from clear that the sacrifice would be uncompensated. Sharing vaccines, etc., is in high-income countries' self-interest, given that high rates of vaccination across the globe is key to global security and stability. Thanks very much.
Thanks a lot, Anthony, for that introduction. Beate, would you like to go next, please?
Good afternoon, and first of all, thank you to all of those people on the webinar. It's an incredible distribution across the world, and it's really an honor to be asked to contribute to this really exciting topic. So as Lisa had already sort of introduced, I am not speaking on behalf of the JCVI or any governmental committee in the UK. I represent really my personal opinion here, which is based on my experience as a vaccinologist. As you know, I direct the Centre for Vaccines at the London School. I'm also an NHS consultant in paediatric infectious diseases in the UK, and I'm based both in the UK and also in West Africa. So my views are partially national, but also primarily international. And if anyone wants to follow me, there's my detail. So, you know, the question here is, do children need to be vaccinated against COVID-19? And there are obviously several reasons why that might be necessary, but there are also reasons why that might not be necessary. And at the moment, just to recap, there is no SARS-CoV-2 vaccine currently recommended for use in children younger than 12. So the entire debate today is really relating to children who are older than 12. And there is a whole issue, which Anthony hasn't actually touched upon, about what we should be doing with younger children. So as he's already said, there are reasons to do this for their own health, to protect other vulnerable members of the community, to cut through transmission chains, to preserve education, but this all needs to be interpreted in the context of equity of access. So what I've done in the next few minutes, I have recapped a little bit on the direct impact of vaccinating children, where we know that COVID-19, for so far fairly ill understood reasons, has actually turned out to be a very mild disease in children, which is very much unlike other respiratory infections. And here's the data from the UK, which summarized the studies on symptoms and signs of COVID-19 in children and adolescents, which was published in July. And pretty much everyone agrees that acute COVID tends to be a mild disease in kids. We have had some deaths from COVID in children. There's no question about this. We had 25 deaths in this age group under 18 between March 2020 and February 21. But the risk of death compared to the adults, and you can see this here on this age-related graph, is really very, very slow, very, very low. So the risk of death from COVID in children and young people is around 2 per million. And the ITU admissions that we've seen in the UK have also been very limited. And half of those deaths and admissions were contributed to underlying complex disabilities. And in most countries, that is already an inclusion criterion for vaccinating that age group. So long COVID. It's a very ill-defined condition. It includes fatigue, headache, difficulties concentrating, and insomnia. And the case definition really could do with some more rigor around it, but it's really, we're learning, weekly about how this presents in children. And it's really the estimate of how long it lasts and what it actually represents is very, very wide confidence interval. And the bottom line is the data that we have shows something between 1% and 10% of children who have symptomatic COVID go on to develop this condition. And this is related to age of the children. It's more common in teenagers. We have data from the UK Office for National Statistics, the international data now, and I've just put you a couple of references here that you might find interesting reading up upon. I found this study very interesting, which relates to an app-based prospective study that was conducted in the UK, is still ongoing, where parents have charted the impact of COVID on their children. And for long COVID, only 1.56% of children had symptoms after day 56. And what was most interesting, that this compared children who had a confirmed diagnosis of COVID and just the symptoms, but had other viral diseases. And actually it showed that the symptoms after this sort of influenza-like illness are exactly the same, be it linked to COVID or not. So I thought this was really quite a very interesting conclusion. So not everything is related to COVID-19. There have been massive impacts of obviously the lockdown, etc. as well. So going back to the vaccines, obviously we need to know that they're safe, that they're immunogenic, and that they're efficacious. And so far, we've only really got one vaccine which has actually included children younger than 18 in clinical trials, and that is the Pfizer-BioNTech vaccine, which is the only one that is currently officially approved for this use. There's some other safety data, and there are now more than 40 international trials going on that are recruiting children and young people as young as 6 months. And you can see the details of these sorts of trials if you're really interested in the vaccine tracker that we've made at the London School, which lists all the trials that are involving children under the age of 18. And I believe in the absence of very solid clinical trial data, we do need to take safety concerns very, very seriously and look at obviously also the implementation data that we have by now. So Anthony alluded to the fact that there might be a small benefit to the children themselves, but there's also a benefit potentially by vaccinating children to protect others. And that is very much the case for children who live with immunocompromised people in their households. And that's already included in the recommendations, at least in the UK. It could also extend to teachers and grandparents, but in the high-income countries, those populations should all be vaccinated by now. Whether they are is another question. And here you see that the majority of the countries in Europe and the US have actually proceeded to vaccinating their under 18s up to the age of 12, and the US and Canada and Israel are far ahead there. So why did the UK make a different decision? The updated evidence showed the included safety data that related to myocarditis in UK, US, and Canada. And what people took into account at the JCVI was that there were very, very limited follow-up data of what is a rare condition, but can present with chest pain, shortness of breath, and abnormal cardiac function for a while. And until this risk is better defined, there was caution within the JCVI. So the myocarditis risk per million is increased after the second dose. After the first dose is something between 3 to 17 per million, second dose 12 to 34. It is a very rare adverse event. And I think overall, we need to be really reassuring about the safety of these vaccines, whichever age group we're looking at. So here's the UK timeline. As you can see, the JCVI recently advised against general introduction for 12 to 15-year-olds, but extended the spectrum of vaccination to specific risk groups. And we are waiting with bated breath of the decision by the chief medical officers in the various parts of the UK to possibly overrule this recommendation on the grounds of other benefits, not just for health. WHO has taken a very cautious approach as well. They said that more evidence is needed on the use of the different COVID-19 vaccines in children. And at the moment, these are not recommended in low and middle income countries. The only one that is suitable is the Pfizer vaccine, as I've said. And WHO will update its recommendations when the evidence or epidemiological situation warrants a change in policy. And given the fact that we have such a large international audience on this seminar, I'm really keen to hear how you've implemented any of this on the ground. And what is also obvious, that we need to continue to recommend the childhood vaccines. Now, when we look at our world in data and look at the share of people vaccinated against COVID-19 in Africa, this remains less than 5%. And we and others have spoken out very clearly that we must not jeopardize the distribution of other life-saving vaccines for children where the benefit by far outweighs the risk, on the back of implementing a COVID-19 vaccination campaign, which stresses all resources already available in those countries. And I've observed that myself in the Gambia. This paper from which was recently published in The Lancet also shows that such expected gaps in coverage exist, and therefore we are also really having to focus on catching up on the immunizations that are supposed to be given and approved for children. Thank you.
Thanks very much for that really useful overview. Govind, would you like to go next, please?
Yes, thank you so much. And I'll go ahead and share my slides as well. So thank you all so much for inviting me, and I'm glad to be able to speak to this big audience about an important topic. And some of this work, not all, is based on a collaborative research and project with Holly Lynch at the University of Pennsylvania and Patty Zettler at Ohio State. But the views here in this presentation are mine, not those of my institution, and not those necessarily of my collaborators. So I actually want to start with the question that some of the other panelists have talked about, which is global prioritization and what the role of pediatric vaccination should be. And my thinking is that it makes sense ethically to use age as one factor, but I think that the idea of prioritizing vaccine access solely based on age, or enforcing cutoffs where everybody below a certain age cannot be vaccinated, would not be appropriate. And one reason for this is that age-based risk is not uniform. So a World Bank working paper indicates that there's a flatter pattern where in developing countries, LMICs, LICs, you see higher relative risk at younger compared to older ages. Similarly, a study by Mary Bassett and colleagues of the United States suggested that in racial minority populations in the US that have suffered discrimination or disadvantage, you also see that even though there's still an age gradient in risk, the disparities in risk actually increase at younger ages. More generally, I think pediatric vaccination is unlikely to be a big driver of global injustice for a couple of reasons. One is that pediatric trials, and I think especially in this group below 12, are using smaller doses of vaccines, so 1/3 or less of the adult dose. And LMICs and LICs also typically have younger populations. The average person in Uganda, for instance, is around 16. And so if you don't have vaccination at younger ages, not having it may actually end up being a driver of injustice. In terms of drivers of scarcity, I think much more important drivers would be, I think we continue not to have fully optimized the dosing schedules and dose quantities for COVID vaccines. You see that in the different ways that the same vaccines were dosed in the UK, for instance, versus the US. I tend to think the UK had the better dosing schedule, but I think we really need to do much better work in dose optimization trials, both for optimizing efficacy per dose and optimizing safety. And then also, obviously, I think a much bigger problem here is going to be boosters as opposed to pediatric vaccinations, boosters that are already being rolled out in some countries and planned in many, including the US, where I'm based. Off-label vaccinations, we haven't talked much about this. My insights here, I think, will be a little bit influenced by the US's approach. So the US off-label prescribing is ubiquitous. It's used in many cases in pediatrics. It's been used for vaccines as well. So for the HPV vaccine, before that was available to kids of both genders, some pediatricians would prescribe it off-label to boys. And in the US, it's actually recommended for the Japanese encephalitis vaccine. There's not an on-label option. So children traveling to a high-risk area are recommended to receive it off-label or have been in the past. Interestingly, in the US, or pediatric research regulations actually require, different from adult research, that the risk is justified not just by social value, but by the anticipated benefits to the subjects themselves. And so given that the vaccine is available through trials, I think it's difficult to argue that the trial dose is ethical to give to anybody in the trial, but should be absolutely banned for provision off-label. I think it would be preferable if everybody could access the vaccine who wants it through a trial, through much larger trials. But for various reasons, trials are full in many places. So I prefer a approach of what I would say is sort of harm reduction, of trying to encourage and give directions on how to give the trial dose, as opposed to the current, at least in the US, approach of just saying no and not really giving guidance about safer and more effective access. I also think even if you permit off-label prescribing, you still have the backstop of professional judgment, just the same as for every other drug or intervention that's prescribed off-label. So I think it's important to have think about a space between universally recommending a vaccine. I don't think you should universally recommend something off-label, and a universal ban. And I think the many countries have taken different approaches. It sounds like in the UK, there's some allowance for access for children at high risk or living with high-risk people. That's not the case in the US right now, and I think that has not been an ethical approach here. I think France similarly has created a sort of way of formalizing access for high-risk kids, and I think that would be preferable. School requirements. So I think some advantages of requirements in schools are, I think the risk-benefit seems broadly consistent, and here it seems in agreement with Anthony's presentation, with other required vaccines, that is that the benefit outweighs the risk. I also think education is a fundamental interest, and to the extent vaccination reduces school closures and disruptions, which has been a big problem in the US, that's a further advantage. In addition to reducing health system pressure. So in some ways, I think hospitalizations may be the more relevant metric to focus on rather than deaths, both because it's bad to be hospitalized, and then also that especially in the US, and it may differ again from country to country, has put a lot of pressure on pediatric ICUs and health systems. And then last, to the point, going back to the earlier discussion, that COVID harms to kids are inequitably distributed. So in the US, about 3/4 of the children that have died, and I think it's looked similarly for serious outcomes, it's come more often from groups that are marginalized racial minorities and other groups. I do think at the same time there are some challenges. So if the goal was really to prevent COVID in unvaccinated adults, ethically it would be better to just mandate vaccines for adults. So if you're worried about hospitals being overwhelmed, better to mandate it as a condition of sort of receiving older age benefits, which is the higher risk group, than to mandate kids just because they're convenient. Education as a fundamental interest also cuts a different way. So you might worry about excluding people who, for whatever reason, have parents that are not willing to be vaccinated. This may depend on disparities in parental hesitancy. And then last, I do think that even though I agree with Anthony that the risk benefit is positive, I don't think that we can say yet that the dosing has been optimized. And so I would like to see more work on optimizing the dosing schedule and dosing quantity might be preferable before moving to the step of a mandate. So just have a last slide, which I'll just leave up before I finish, which I do think there are these factors beyond risk benefit that come up and are worth thinking about. So on the pro side for vaccinating in pediatric settings, it's especially bad to die early. Not all deaths are equal, and it is especially bad, I think, for someone to die having had very few years of life. It's also true that kids that are high risk are typically otherwise disadvantaged. I mentioned from poorer countries in the US, often from groups subject to discrimination, kids with complex disabilities. And then last, kids don't have very much political power. So I worry about this with saying, well, we'll send their vaccines to deal with global injustice. And they don't really control their exposure to COVID either. On the con side, I do think we are still optimizing dosing. And it's true under scarcity that COVID risk, even though it may not increase with age at the same rate in all settings, does increase with age. So that's why I think age can be a reasonable factor in distribution. The last one, which I don't like, but it comes up a lot, is this question of, well, it's important to reassure the public about vaccine safety in particular. There's some sort of asymmetry between somebody being harmed by a vaccine, which is worse, and somebody being harmed by COVID, which is fundamentally less bad. That I worry about ethically. I worry about, it does not seem to be ethically appropriate if somebody's risk benefit personally looks positive to deny them access on the basis that we're worried about how their potential side effects from vaccine could impact public assurance about vaccines. But I'll be very interested for the audience's thoughts and comments. Thank you so much.
Thank you so much for that really helpful perspective. I think you made a lot of great points that are not often, haven't received sufficient attention in these discussions, for example, about the asymmetry you mentioned at the end. Yeah, so we've received quite a lot of questions from the audience, both at registration and during the discussion. I think it's really good to come back to a lot of the points you each made in your introductions. But I'll try to take some of the questions from the audience and try to do it that way. So we've received quite a lot of questions about the uncertainty point, which relates to the asymmetry you mentioned at the end, Govind. I was wondering whether each of you or either of you would like to say something more about the uncertainty point. So for example, do you have fixed ideas about the threshold of certainty we ought to meet before vaccinating children? Do we know enough to vaccinate children now? And if not, what would need to happen before we proceed with vaccination? So what else would we need to know before we proceed with vaccination? And how should we think about this in relation to the risks associated with COVID infection? So how much COVID infection risk can we put up with while delaying vaccination? And how should we deal with the uncertainty regarding short and long-term effects there, and so on? So yeah, someone in the audience also asked, a lot of people have asked about the risks associated with the vaccine, but at least one person also asked about the extent to which it's ethically permissible not to vaccinate children, given their limited ability to protect themselves from infection and so on. So I was wondering whether anyone would like to say something more about the uncertainty point.
Well, I can try and kick off with some, more medically oriented questions around that. I mean, to some degree, people want to have their cake and eat it, because there was a huge amount of pressure on getting the vaccines developed as quickly as possible. And I think the scientific community really did a great job there. People then had a hard time to actually accept that the testing of these vaccines was done rigorously, because we just managed to do things much more rapidly by having parallel sequences, and the money was thrown on the table. I mean, these are the two main reasons. And I think the safety data, one of the issues was that because of the sensitivities around new constructs, no children were included, primarily in the vaccine trials, and also because the burden of disease was lying with the adults. So I think that's all to be understood. But as a consequence of children not being included in the trials, we then had virtually no safety data from anything relating to an age group less than 18. And it's only now that that's coming through. And I think it's really a good idea to optimize dose intervals and really look at this. And I think, with the myocarditis issue, it is very rare. But in a situation where the health benefit is going to be very minor, I think it's a responsible position to take, that we should be looking at the risks of the longer term outcome of these children for a little bit more, because people doing cardiac MRIs in the US, for example, to just see whether, apart from the parameters, they've come back to normal, there might be any longer term issues there. And I think those data I'd love to see before we really come to the conclusion that everybody should have that vaccine.
Thank you. Anyone else want to weigh in on that?
Yeah, I'll just say one thing. So everybody sort of picked up on this idea that the costs or the risks associated with vaccines were to be weighed more heavily than the benefits. So we might think that's a legitimate position to hold in the position that you described, Professor Kampmann. But now that we have lots of real world data, lots of children in the United States and Canada and other places in Europe have been vaccinated, and we're able to see sort of what the outcomes are. Is that still, in your view, a responsible position to hold?
Well, I think so, because as I said, we know what the acute outcomes are, but we don't have any follow-up data on these children, right? I mean, if you remember, the vaccines were starting to be given in this group after May. So we've got 3 to 4 months data. And I don't think it's unreasonable to watch that space a little bit longer.
So then is the idea that the uncertainties, for example, associated with waiting, or the uncertainties associated with, allowing exposure to COVID-19 for children, are those to be weighed less heavily than the uncertainties to do with vaccines? So of course, the longer we wait, the more likely it is people will be exposed, especially with new variants and lots of countries, relaxing protection measures and so on.
Yeah, I mean, we don't want to hijack the discussion here, but I also think that it's not just the numbers that count. It really counts which numbers of children ending up being admitted to hospital, which numbers of children are passing on infection. And in a context where the majority of the population should be vaccinated, and I know that there are challenges, particularly also in the US, I think to work towards, and Govind also alluded to that, I think the efforts should be geared towards trying to persuade those people who would come to much more serious harm to take up their vaccines rather than focusing the emphasis on children.
So I have some thoughts about this. I think it's useful to distinguish two questions. One is, should a vaccine be universally recommended for everybody in a group? And the other is, should the vaccine be universally prohibited for everybody in a group? And in the US currently, and I think this has been the position in some other countries, what we have is a universal prohibition. So the choice, at least for the very youngest groups, we haven't seen, I think, and I think it's preferable to have something more nuanced. I understand that risk benefits may be different for different groups, but I think in terms of saying, we should wait or have more data, I'm not fully sure how to think about that. It seems to me, at least my view, and I haven't been fully clear what my other panelists' views are, is that in the end, there's uncertainty both about sort of effects of vaccines, but also uncertainty about the effects of COVID-19. So in the end, I tend to think, and I wasn't sure what your views were, that there's nothing either especially good or especially bad. I mean, it's bad if anybody suffers harm, but it's not worse, I think, if it comes from a vaccine than if it comes from a unknown infective agent. And so in the end, I think you just have to do the best you can at optimizing the risk-benefit balance under uncertainty. And my view is sort of, given the information that we have, I think it's responsible for many countries to go ahead and have vaccination in younger groups while continuing to collect data and being clear that as you get more data, your recommendations may change. But I'm not sure that there needs to be a pause while data is collected. And I think this may just be a difference in perspective. I think if it looks like the risk-benefit balance is favorable, given uncertainty, you can go ahead rather than waiting, but then be prepared to change course if your uncertainty clarifies in some way. I think there are other settings where people have a different view and think that you need to wait for certainty as opposed to proceeding under uncertainty while being ready to change course. And I guess I wasn't clear, Professor Kampmann, from your view, whether you thought that there was genuinely an asymmetry between harm from a vaccine and harm from an unknown disease, or whether you thought that, whether you didn't think there was an asymmetry, but you thought that it was a function of just the actual risk-benefit balance with no asymmetry.
Yeah. Okay. Well, let me clarify that a bit. I think there shouldn't be an asymmetry, but there is an asymmetry in perception, and it's partially fueled by vaccine confidence discussions, which play an enormous role. And at least, you know, there was a notion being made that this should also be mandatory. And I think, and we can maybe move on to that topic a little bit. I think at the time when the data are still somewhat limited, I think to introduce this as a mandatory vaccine would be really, I think, a step too far. And we do need to address the vaccine confidence issues that are out there. I mean, it's one of the leading causes of vaccine refusal. And I think we're not just having to consider the uncertainty in the context of the COVID vaccines. I think we have to work with populations in all settings, including in LMICs, to have confidence in the decisions so that all childhood vaccines are taken up in the way that, you know, we know that they will be of benefit. So I think we need to take that wider perspective also into account.
Thanks very much. That's good. Yeah, it would be good to maybe say something more about mandates. If I guess Anthony has come out in favor of mandates, and Govind also mentioned mandates, and Beate has perhaps already partially answered this question, but I was wondering if we think about vaccine mandates, do you think mandates for children are harder to justify or easier to justify and than mandates for adults, or and are the considerations that speak in favor or against mandates the same for children and adults?
So I think in general, it is going to be how easy it is to justify a mandate is going to depend on what the individual and societal benefits are of the mandated intervention versus the risks. And I do think that the case for mandates in adults from a risk-benefit perspective is actually stronger than the case. That doesn't necessarily mean that mandates are inappropriate in children, but I actually do think the case for the mandates in adults would be stronger. At the same time, I do think there are specific factors with children that make it more complicated. So one is this issue about lack of control over exposure, which is that children may not have a choice about whether to go to school or about other ways in which they might be exposed to COVID-19. And so that may actually cut in favor of mandates insofar as children have less of an opportunity to control their exposure in response to others. And so it may seem, I think one of the Q&A questions asked this, may seem sort of more responsible to have a mandate to protect children, as opposed to in a realm of sort of choice, there may be more of a situation where children end up being exposed without having that opportunity. So I think I think that the case for mandates in adults is stronger, and it does bother me if we are the extent to which the fact that children are it's just sort of more typical to have mandates in children. That's not necessarily an ethical argument for doing it. But I would say I tend to agree more with Anthony that it seems, at least in certain countries, depending on what their COVID outbreak looks like at the time, it looks to me like it would be permissible. There may be countries, if a country can adequately control COVID without needing to have any mandates or without needing to have childhood mandates, that's obviously better. I don't think every country is in the same place in this respect.
Yeah, so I think I agree with most of what you said, but I think it's important just to emphasize the sort of ways in which the two populations are vulnerable, like you said. So children have a harder time, avoiding COVID-19. Like you said, they're required to go to school and things of that nature. So that makes them in some ways more vulnerable than adults, even if the risk-benefit profile for adults is better. So I would sort of, want to err on the side of protecting their vulnerability, and also, in addition, protecting them from, as you rightly pointed out, more serious costs associated with their deaths, and also with some of the longer term effects of their infection. Just wanted to return to one other point about uncertainty. So yes, well, of course, we should weigh heavily trust in vaccines, and maybe that's a reason to be particularly concerned about harms of vaccine, but we also want to increase trust more generally in public health initiatives and public health measures. And so, one way we can do that is weigh that into the calculation too, and that might be in some ways affected by waiting too long or waiting for too much certainty with respect to proceeding with courses of vaccination for, in particular, these vulnerable populations that have a more difficult time protecting themselves or being protected from COVID-19, particularly in places where there are relaxations of public health measures like masking and social distancing and so on.
Yeah, thanks very much. Did you want to add something, Beate, or
No, I think, that discussion, we don't have mandatory vaccination in the UK, and it's not an approach that is really embraced by our public health measurements. So I think this is a little bit weighted towards the North American perspective. There's no mandatory vaccination in low and middle income countries. And I think we need to put this into a slightly more global perspective with regards to what is actually known in society about acceptance of mandatory vaccination before I would recommend that.
Thanks. Yeah, it would be good to move on a bit to the more global perspective, maybe before we wrap up. So I think we've received a lot of questions about vaccine access and global equity and things like that. And I think the issue of global vaccine access is probably the most important question. But I think it's a bit unfortunate that it's so often discussed just in relation to the vaccination of children and not more generally, especially because as I think Govind discussed it here and also in previous work, age is not all that matters for COVID risk. And as Anthony has noted in previous work, the priority argument, so the idea that we should prioritize people who are more vulnerable or less able to protect themselves, especially in low middle income countries, could have been introduced at any point in vaccine rollout. So would anyone like to say a bit more about the priority argument and how it plays out in the context of vaccinating children vis-a-vis in the context of vaccination more generally and prioritization?
Sure. So I think it's important to differentiate within a country and across countries. I think it's unfortunate and unethical that we have such greater scarcity in lower income countries compared to higher income countries, which sort of boosters exemplify. So I think within a country, they should be able to, every country should be permitted to prioritize according to their national risk. And that will often involve prioritizing their own older residents over younger residents under scarcity. But I think at a global level, if you were to set global age-based cutoffs for countries to get vaccines, that will actually work to the disadvantage of countries that have a population that tends to be younger as opposed to older. So I think it's important to differentiate the question of intranational prioritization under scarcity from the question of global vaccine distribution or a sort of global cutoff for access or recommendations.
Yeah, I think I would totally agree that, we can't trade in one bad thing for another. We really have to prioritize the overall availability of vaccines. It's not a question of, I give you our childhood vaccine so you can vaccinate your adults. Although I have to get back to Anthony around the IP question. And I think this is a really important discussion, but the IP rights are not going to be the only thing that will determine whether countries will be able to produce their own vaccines. This is a very lengthy process. And I mean, there's much more international commitment now to enable other countries to also get on with vaccine production, but this is not going to come off within this pandemic, is my worry. And, it needs a lot of expertise and it's huge investment internationally to make this happen. The first thing is the commitment of the African Union and clear milestones and a sort of roadmap how to put this into place. But in the meantime, we need to continue, as you also say, share these vaccines and make them available to the countries. But we mustn't underestimate the enormous challenge that the countries with the resources within the EPI system have also come under. It's literally the same people who are dishing out the COVID vaccines, who are dishing out all the other vaccines. And that's the reason why so many other vaccines haven't been given. So I think it's beyond the IP, but we need to work with COVAX and the various initiatives that have been there to make more vaccines available. And I think it's a scandal that we've been hoarding them in high-income countries.
Yeah, so I think I agree with that. It's just one part of the means by which we achieve vaccine equity, and certainly distribution and capacities are a huge factor in this. And of course, it makes it all the more appalling that countries are resisting relaxation of IP rights because that's a distraction from, as you say, the real issue, which is access and also just building up the capacity for future pandemics and also just having fairness in terms of ability to promote your population's health. I think sort of as you say, some of the discussion of mandates is premature for many jurisdictions. Many jurisdictions is really just access. And then the question would be then how do you develop the capability? And I think, our obligations in high income countries are to put aside concerns about property rights and so on, and really focus on this issue of delivery and capacity and providing the basis for, a fair opportunity for engagement.
Yes. Does anyone have any ideas about what we as residents of high-income countries that are failing to ensure vaccine access in low and middle income countries? Is there anything we can do? Do you have any ideas about that?
I think a couple of things that would be really valuable. I do think boosters is going to be a huge problem. I think much, much, much bigger than any of these issues about pediatric vaccinations. The US takes up, 300 million. It's not going to be that many, but 200 million doses as boosters. The other is this issue about dose optimization. I continue to think we have some work in progress under review about this. Optimizing the dosing schedule and optimizing the quantity of vaccine used might both improve the risk-benefit profile, including for children, and allow scarce vaccine quantity to be used in ways that draws on less global supply for vaccinating children, and so leaves more supply available for countries where not enough people have been able to access vaccine, even in groups that are higher risk on average than children. So I would really like to see. I think it's been really irresponsible. It's understandable that we had to sort of rush out of the gates, but I would like to see much more work on really trying to optimize dosing. I'm glad to see these mix and match trials. I also think it's worth recognizing, some speakers made this point, questioners, risks of different vaccines may be different. I'm very keen to see what the risk-benefit profile looks like for Novavax, for instance, in this group. So I think it will be really valuable to understand more about how to use our total global supply to maximize the sort of per dose benefit. And I think we're very, very far from doing that, even though what we've been doing has had huge benefits. I don't think we've optimized this.
Thanks. Anyone else want to weigh in on that?
No, I agree with the statement from Govind. I think it's totally right.
It's good. I'm afraid that's all we have time for today, I think. I'm really sorry that we didn't get to all of your questions. There are lots of really great questions, and it would have been really good to continue this discussion for a lot longer. But I think we're out of time now. I would like to thank our panelists, Anthony Skelton, Beate Kampmann, and Govind Persad, and the Global Health Network and Epidemic Ethics for organizing and hosting this event. Thank you so much.